So talking about just kind of some statistics to give you an idea of how eating disorders happen with kids these days. And these are actually a few years old statistics. I assume they're probably worse now. Over a third of ninth grade girls think that they're fat. Almost half of girls report teasing, and 25% of boys from their peers about their weight. I have noticed a huge trend lately of junior, seniors in high school, early college age people who were overweight and they got picked on, and they just decided one day that was not going to happen anymore, and they started dieting and they got an eating disorder, basically. It just went over the edge. And so those people are extremely hard to treat. I would say they're probably second behind the really, really young ones in their black and white thinking, because they don't have the quote unquote normal to go back to. So with other people, when I'm doing therapy, I can talk about what you used to enjoy. Didn't you like having pancakes on Sunday mornings with your family? And remember when you could just do that and it was normal and you didn't care and it was fine? These people, it's really hard to do that with, because they associate all that. Well, yeah, when I had pancakes with my family, I, was 40 pounds heavier and everybody hated me and I got picked on all the time. I'm not doing that again. And so they're another really difficult population to treat, because you're essentially teaching them to go from one extreme, from the other extreme, to finding the middle ground. And it's hard. So teasing is a big deal. A lot of girls who smoke cigarettes are doing it as a form of weight control. So if you have a patient that's smoking, ask why. What we know about people who diet, 14 to 15-year-old girls who engage in strict dieting are 18 times more likely to develop an eating disorder. The MyFitnessPal app, check all your patients' phone. If they have that, to make them delete it. They're not allowed to have that app. It's horrible. Anybody have? I don't even want to know. It counts your calories for you, and you put in your exercise, you put in what you do all day, and it gives you this running total. And I've had patients try to get it to 0, so their exercise and their calories balance out. You don't need 0. Your body has to have calories to function. And it's just an easy to become obsessive. It's this competitive with themselves sort of thing that, well, yesterday my number was this, so today it's going to be 50 lower, and tomorrow, and it just goes on from there. Again, because we know that you don't get abstract thought until about age 15. So remember when you were 15 and suddenly you realized other people think different than you? And I remember being in 9th grade and my best friend going, what if how you see yellow isn't how I see yellow? Because we thought we were like these brilliant philosophers, right? Like, whoa. Because we just got abstract thinking. So it was exciting. Our brains were changing. And we didn't even know that's what was going on. We just thought we had a stroke of genius. And so up until that point, it's pretty black and white for people. And so they don't really understand balance and gray area and exceptions. And it's okay to have things sometimes. And even past that, what I typically find is there's almost like a magical switch. And one day I'm going to find it. I'm going to name it after myself. Because that's what people do. So it's like there's this switch in the body that when people get to a certain point of dieting, it's the point of no return. And all of a sudden, it's like nothing is enough, and they've turned on that eating disorder switch, and now it's an obsession, and they just can't get away from it. And the hard thing is, I really believe this switch is in all of us somewhere. And when you look at the studies, if the starvation studies that the Nazis did, then those guys didn't want to eat anymore. When you look at, there was some guy, stupidest thing ever, decided he was gonna find out what it was like to be anorexic and start a documentary, and actually kind of gave himself, if you will, anorexia, for lack of a better way to put it, because he lost so much weight, his proverbial switch flipped on, and he couldn't gain the weight back. It was very difficult for him. And so I think it's in all of us somewhere, but most of us don't ever get to that point. The hard thing is we don't know where it is. And so for some patients, it might be just a few pounds below, their ideal body weight or their normal kind of maintenance weight. For some people, it might be 30 pounds below. We don't know, right? So a lot of times people are engaging in simple dieting, they think, and then it just really gets out of hand and turns into something else, and now it's out of their control. We know, speaking of dieting, that 95% of dieters they're all going to gain it right back. 35% progress to pathological dieting, and that's kind of what we just talked about, because not everybody can just do it normally. And only about, I could tell you so many, I'm sure you guys know all the statistics about how we don't look anything like what we see on TV. Y'all know if Barbie were real, she'd be 7 feet tall and would fall over, and she wouldn't be able to hold her intestines. And 47% of TV stars meet criteria from a physical standpoint for an eating disorder. There's all kinds of stuff, right? We know that the media is absolutely not realistic when it comes to its portrayal of people. And while I am definitely not one to let the media off the hook for what they do to us in their portrayals of the thin ideal and how they promote that, at the same time, we know that it's really, media is just a small portion, right? I believe that there's all these other things going on, and if we lived in a country where there was a different emphasis on things, then people would probably develop other problems instead of eating disorders, right? I think that the media is probably what makes that category more popular, but it definitely comes from a host of other issues. And we know, of course, people are influenced by magazines. Actually, they did a great study of 15-year-old girls, and they let them look at a teen magazine for 5 minutes, and then they gave them self-esteem measures, and their self-esteem went down like 20% after 5 minutes of looking at a magazine. They're horrible. Don't get your kids magazines. So comorbid disorders, as you talked about, anxiety and depression, about 66%. Obsessive compulsive disorder, about 40%. Drugs and alcohol, about 25 to 50%. Now, what we find with this is that it's primarily with bulimia that we see the drug and alcohol problems, because if you think about what we talked about with boundaries, the permeable boundaries, they're much more likely to bring things in. We see a lot of alcohol and substance problems in our binge eating population. We see fewer in our anorexic population, because alcohol has calories, so they're not going to drink it. And also, these little over-controlled individuals don't like being out of control, and substances put you out of control, and so usually that's a little much for them. What we do find with our restrictive patients is that when they are using alcohol or something like that, then they're not eating, so like they'll have a bottle of wine for dinner or something like that, which is obviously even more dangerous for your liver and the health consequences of that. So we do see some of that where they're sort of extreme compensating for what they do have, but for the most part, it's going to be more of your bulimic and binge eating patients that have substance use issues.
I think the anorexic are more likely to use like ADD medicine so they're not
I get asked that a lot, and I haven't really found that to be true, and I haven't seen any good research on that. I am sure that there are people that do. There's a whole treatment center actually for people who are bulimic. They call it diabulimic, who use insulin as a way to lose weight, manipulating their insulin. So absolutely, people do all sorts of things, but I haven't seen that being a super prevalent sort of thing. I think part of it is typically this is very stereotypical and yet true. For the most part, your anorexic patients are more, they usually are really good kids, so to speak. They make really good grades, and they're very perfectionistic, and they want everybody to like them, and they want to do the right thing. And I think in order to go med seeking, they would just be too worried about what people would say about them and the judgments that would come from that, and so they don't. So not saying they wouldn't if it were handed to them, but I think that the sociocultural factors prohibit some of that with that population.
They might abuse like diet drugs?
Absolutely, more diet pills would.
Them then getting into things like meth or something like that, which is...
There's a chicken and the egg thing when we talk about substance use, as far as what comes first, the eating disorder or the substance use, and it really goes all ways. So sometimes you'll have people that have the eating disorder, and then of course all the anxiety and the feelings around that it leads to substance use. And then sometimes you'll have people who are using substances, and again, it's that kind of proverbial switch, right? They get that heroin diet going and they start losing weight, and now they've activated the switch and now they want to keep losing weight. Just for reference, the hierarchy of treatment is always substance use first and then eating disorder. So if someone comes to us, and we've had active heroin addicts come to us, and it's straight to rehab, and then they can come back and do the next phase of work with us. PTSD. So the old misnomer was if you were bulimic, you'd been sexually abused, right? Anybody heard that before, that kind of stereotype? Not true. What we know is that 80% of people with any eating disorder have had some sort of abuse. Physical, sexual, emotional, neglect, something. 80% sounds like a lot, but that means there's still 1 out of 5 that hasn't had any of that. And those people have a real hard time validating themselves. They're sitting in treatment with these people who have these horrible stories, and they're like, oh my gosh, I've had this normal life, when really everybody's had junk, right? But that is something else when you're going through treatment with somebody who hasn't had a really significant trauma. We call it trauma with a big T, right? There's little t trauma and big T trauma. So the significant big T trauma, it's difficult. And that's something you want to make sure that you're kind of validating with them and exploring with them and normalizing for them that eating disorders, we know, are partially genetic. We know that there's a lot of different things that cause them. They're biopsychosocial. And so the social is just one little piece of that. And their trauma history, is one little piece of that. There's a high heritability rate, about 50% genetic concordance with twins. And I can tell you anecdotally, for us, if we see one twin, we're going to see the other twin. We've had a large portion of twins too come through our clinic. It's amazing. I don't know if it's the kind of wanting to stand out and be different, or what it is. We see a lot of twins. We know that there's a huge genetic piece when it comes to the factors that contribute to an eating disorder. So when we look at temperament, people with an eating disorder tend to be perfectionistic. They tend to be obsessive. They tend to have higher anxiety levels. All of these things we know are genetic. So there is a strong genetic component, and there's increasing research coming out now. Stanford's doing a whole lot of brain research and really looking at the genetics piece of things. So we're learning more about that every day. Other than that, if you think about it, it's a little bit hard to tease out the genetics piece from the family piece because most people are raised by their genetic parents. And mom and dad, whatever their eating style is, really transfers to the kids. And it transfers in 2 ways. So a lot of times what you'll see is that I had one mother who, her mom, and this is a great example of how both sides work, right? So this mother, who's probably anorexic herself, her mother had diabetes, and her whole family had been obese. So she decided there was no way on earth that I'm going to do that, and I'm not going to let my kids end up that way. So she used her family history and went to the opposite extreme, right? So I'm not going to eat, there's no sugar allowed in our house, there's no this, there's no that, and very restrictive eating. Her twin daughters then decided she underfed her twin daughters basically her whole life, and they were always really small and that sort of thing. Well, then once they got a little bit older, then they picked up on that anxiety and they really stopped eating. And so then they were building on what mother did and doing a similar thing, right? So that plays out in 2 ways. The daughters both end up passing out one day, and they end up in the hospital, like the Methodist hospital, and that's how their eating disorder was discovered, because mom had really been underfeeding them. And I don't think she did it on purpose. I think she did it with the best of intentions so that these children would not have diabetes, and yet they ended up with anorexia instead. And so we do see a big family component when it comes to the development of eating disorders. So, of course, we know it can be in men, women, boys, all different shapes and sizes. You really can't judge somebody from looking if they have an eating disorder or not. And if someone doesn't look like they have one, then it's even harder for them to justify treatment to themselves. So it makes it even more difficult. Anytime people have like sudden weight loss or extreme weight loss, you want to ask questions. So, for example, I had a patient who was 14 and she was overweight. She lost 60 pounds in 2 months. Her heart rate was in the 30s. It was so low, she had to be airlifted to, her family was overseas in the military. She had to be airlifted to the States, for treatment. And so by the time she got to us, she was actually a normal body weight, right? She had to gain maybe like 2 pounds to be in what we would call her IBW. But obviously very anorexic in her mindset, right? So anytime somebody's losing weight rapidly, you really want to ask questions. That's a big thing. Even if they're legitimately overweight, right? And it's a health. You think, well, they're getting healthy. That's great. You still want to ask if it's too quick, and if it's not. You just want to know how people are doing it, right? If they're your patients, you want to check. And so you should definitely always ask. And then any kind of also rapid weight gain. So I had one patient who would gain and lose 30 pounds. Every month or two. It was just constant fluctuations. And why the people in her life were not, what is going on with you? I do not know. But we want to ask these things. And I think that the hard part when we talk about looking at food and looking at weight is even us as clinicians, when we're talking to our patients and when we're talking to our patients' families, it is such a sensitive issue, right? We're trained not to talk about weight, not to talk about what other people are eating. Everybody, I think there's this kind of idea that, everybody eats different, right? It's, who knows? Everybody kind of eats their own way, does their own thing, and yes, and we need to be asking those questions to make sure that we're not missing a disorder that should be a part of treatment.